All right, so without further ado, I would like to hand this over to Hamish, who will take you through the agenda for the evening, and have a great time.
So I'm Hamish. I'm a fourth-year medical student from Tufts. I'm part of the main track program. And this is the Primary Care Progress Second Annual Town Hall meeting. We're going to be focusing on kind of a narrow band of the interaction between homelessness and substance abuse and how those things interface with people's healthcare and healthcare delivery in general. These are our objectives. We have 4 of them. We want to identify all those complexities that are associated with homelessness, as I kind of just suggested, and look at how they affect health. We want to make sure that everybody here has an increased level of comfort after this in discussing and assessing substance abuse, especially in that population. It's never going to be necessarily comfortable, but we want you to be more comfortable, is the idea. And then looking really closely at how caring for people who are homeless and experience substance abuse trouble, how that interacts, how that affects a healthcare team, because there can be a lot of ways that people react to that, and recognizing your own reactions and making sure you're policing that when you're taking care of people in this population is important. And then looking at some resources, we actually are going to be circulating some resource sheets with a list of stuff that's available in Portland and the greater Portland area. So we want to help you make sure that when you walk away, you have at least 3 or 5 resources that you can think of right now for different ways of helping people who are homeless or have substance abuse if they come into your clinic or if you see them in some capacity. We have some sponsors: Tufts, UNE, IPEC, UNE's ESPRIT program, the AHEC Network of Maine, and Maine Medical Partners. We'd like to thank all of them for helping make this possible and giving us some financial support. So we can clap for them, I guess. Sort of a quick aside before we do a little bit more of a detailed introduction to the program by some of my colleagues, and to get a sense of who's here with us in the room. Separated not by students versus sort of professionals, who here is associated with a social work program? So decent. We got a good social work turnout. Nursing. Awesome. How about dental? Very good. Pharmacy? Very awesome. And then physicians, MD, DO, whatever. Great. Anybody I missed? What kind of subgroups am I missing? OT, all right. Anybody PT? How about you? Also OT? All right, we got OT. That's great. So we got a pretty broad group, which is awesome. That's kind of part of the goal. And now a couple of my colleagues will.
So welcome to an event that is primarily hosted by Primary Care Progress. And you might be saying, who are we? Who are these people? And we are an interdisciplinary team that is made up of students with all of the professions you just listed. So medicine, social work, dentistry, occupational therapy, physical therapy. We really are a group of students who are trying to make our community better and better understand our community needs. So you're welcome to join us, and if you put your email down, we are happy to reach out to you, and you can join our meetings, and you can be part of the creation of lovely events just like this.
All right, and I'm just going to read our chapter mission to you guys. Our chapter mission is to transform and improve primary care in Maine with a focus on leadership development, interprofessional collaboration, patient care, and community outreach to high-risk, underserved populations, which is pretty much what this talk today is about.
All righty. Thank you, guys. So we have one remaining thing to do here before we go a little bit further with it, which is introduce our community panel. And these are all people who we selected who have experience in some component of the story that we're going to lay out for you over the course of the evening that we think will be helpful in teasing your brains about what you'd sort of face in treating somebody who is homeless or has substance abuse. So we have Adam Normandin. He's a doc. He's right here. And we're going to set up the chairs in a second, once I turn the little projector off and it doesn't blind people anymore. We have Malia Haddock, who is right here. Awesome. We have Ann Bartlett, RN. Also right here. Awesome. And Joni Clayman, LCSW.
Well, good evening. I'm Joni Clayman, and I'm one of the directors of social work at Preble Street. And I'd like to start off by sort of explaining in terms of who we are by describing our mission. We are very mission-focused, and that sort of drives everything that we do. So our mission at Preble Street is to provide accessible, barrier-free services to empower people experiencing problems with homelessness, poverty, housing, hunger, and to advocate for solutions for these problems. So it's very important in terms of the advocacy as well as the provision of services so that we're all solution-oriented. So we do this in very many different ways. Preble Street was founded in 1975 by a social work professor, starting with social work students, and has evolved over the years, starting with the Resource Center, which many people know, in terms of providing basic needs and shelter, and whether it's showers. If you're homeless, how do you get a job if you don't have an address or a place for a phone to come in, receive a message? How do you apply for benefits if you don't have access to people who can help you to do that? So we have very basic needs. We have soup kitchens. We have caseworkers who are working every day with folks towards their goals to move out of poverty, homelessness, and hunger as best as possible. We have these food programs. We have soup kitchens that are serving approximately 600,000 people a year. We have the Anti-Trafficking Coalition. That also provides support to people who are trafficked, both sex trafficking and labor trafficking here in Maine. We have our Veterans Housing Program helping to help people end homelessness for veterans in Maine, and also prevent homelessness. We have Teen Services, which provides overnight shelter for teens 12 to 20, and also daytime drop-in services, again, basic needs, casework. We have what we call our Housing First programs, and there's brochures for all of this, and it's really important to understand the Housing First is an evidence-based approach where people who are living in homelessness can get out of homelessness, have their basic needs taken care of, and it's amazing what can happen when you're not worried about where you're going to be the next few minutes, when you're not worried about surviving tonight. What can happen, what can evolve at a pace and a time that is based on the individual's needs. I think we also have Florence House, which is our women's shelter. So in addition to the apartments, permanent housing, part of our Housing First program, we have the overnight shelter for women. So you may also hear about Logan Place, you may hear Houston Commons, those are part of the Housing First programs. So we do a lot, and I don't think I mentioned everything either. We have our advocacy programs. And we have the Maine Hunger Initiative. We have Homeless Voices for Justice, who's been instrumental in changing how policies happen and how people who are homeless are treated in this state. So there's a lot going on. There is a lot of effort to try and work with individuals to move beyond at the rate and pace that works for them. So there's a lot of materials up on the table, so just happy to suggest that people take a look at that as well. And then I also want to mention, speaking of Malia, but for the segue, in terms of we have our health services program, which is a very exciting new collaborative that we have the health services with Preble Street collaborating with the Maine Medical Center and Homeless Health Partners at the Learning Collaborative, which is really providing such opportunity for so many people Adam, I mean, all of us up here are very much involved in this, and really looking at how we can affect change around the social determinants of health, how we can understand the lived experience of ACEs, the adverse child experiences, and really help people move forward in their goals. So we're doing that. Our new health services and learning collaborative has been an exciting new endeavor to work towards that. So that's a segue over to homeless health partners.
So my name is Malia Haddock, and I oversee Homeless Health Partners at Maine Medical Center. We are a small but mighty social work program that is based out of, as Joni said, the Preble Street Learning Collaborative, which is a really wonderful, relatively new initiative that seeks to bring together really all of the health professions and social work professions with learners at all levels, and engage everyone in the care of underserved patients in our community. And at the same time, provide positive healthcare experiences to patients who have, for any number of reasons, been disconnected from healthcare for, sometimes 20, 30 years. So the program that I run, we provide, and you'll probably hear the term low barrier. We provide low barrier, as low barrier as possible, social work case management services to people who are either experiencing homelessness or who are at risk of homelessness or have a history of homelessness. And we provide support to patients around their health care. And because so many of the patients that we work with are uninsured, we oftentimes partner with a Preble Street caseworker who work on sort of more of their holistic social work or basic needs, and we provide case management around their medical care, and we provide what's like a wraparound service to patients who have no payer source. We receive referrals from, the most referrals we receive is from Preble Street, and then I think last year, like one fewer was Maine Med. So those are the bulk of our referrals, but we have referrals from actually quite a few from Milestone, increasingly so, from Mercy Hospital, from the YMCA, the Salvation Army, really any sort of community partner in Portland area can give us a call. And what we try to do with our team is to sort of take advantage of seize the opportunity of the moment. When somebody is in need, we try to go and meet the patient where they're at and try to build a relationship with them. So I think that, as we talk, more throughout the evening, I think you'll continue to hear the importance of relationship and establishing trust with patients who have very good reason to be distrustful of systems that are intending to help. So we do a lot of work on the front end of building a relationship with a patient. Our approach looks and I think feels different from a lot of traditional social work programs. And for those of you who are in social work, maybe have had positions where you hear, I'm not going to do more than 50% of the work for the patient. I need the patient to initiate services. I'm not going to chase the patient. We initiate, chase, and sometimes do 100% of the work initially. And we do that not to disempower patients, but to show people, like, you can count on us. We're going to show up. If you don't go to your appointment, we're going to come and find you. And when we do find you, we're going to go with you to the appointment. So it's a very hands-on approach that we take. And over time, what we're able to do is, gradually step back and away so that patients can more or less navigate the system on their own. We do a lot of, while our sort of, where we do our documentation in the health record is at the collaborative, most of our work is in the community. We're at the shelter, we're at the YMCA and our sort of pilot, or 4 respite beds that we have there, in the hospital, in the jail. We do a lot of work with the Housing First programs that Joni talked about. So each each Housing First program has a dedicated homeless health partners case manager that is, that's kind of their niche, where they're building really close relationships with the staff and really close relationships with the tenants there. I think a big part of the work that we do really is our documentation. In terms of making our patients known and visible in the electronic health record. So that is something that over time we hope will benefit all of our patients, so that providers like all of you, when you're in the system and you see a patient that has an ICD-10 code of homeless, you see that they have homeless health partners on board, you see that they reside at Logan Place, or maybe that they got into care because we met with somebody at detox, it's going to trigger something for you, that this patient is carrying potentially a lot more around with them than might first meet the eye. So I look forward to any questions that folks have, and thank you for being here.
Hi there, I'm Adam Normandin. I'm a third-year family medicine resident at Maine Med, and I have been involved with the Preble Street folks here for a couple years. I had spent some time during the years between undergrad and med school volunteering with Boston Healthcare for the Homeless. So we mentioned Dr. O'Connell coming next week. That was sort of my path to here. And then as I was a second-year resident, Preble Street Learning Collaborative had tried to fill this gap and open this new, as Malia was saying, low barrier, open door clinic for people that had whatever acute medical need they needed, and that we could try to capitalize. A lot of these people, as has been alluded to, were really ostracized in one way or another. But they would come in, and maybe it was that they just needed some ibuprofen for a headache, or maybe they had some chronic wound that we would do dressings on for them. But whatever it was that we could, get them in, build relationships, and try to get them assimilated into the medical system that already existed. So we weren't necessarily trying to be people's long-term doctors, but just trying to be a venue to get them in. As a resident, and particularly family medicine, I kind of have the privilege of being able to be in a lot of different areas. So I have, clinical time and hospital time, and then elective time. And so my elective time has been able to be down at the collaborative half day or more a week for the past 2 years. And the other nice piece about that is that I get to be involved in patients as they transfer from each of these different environments, and there are a lot of things that get lost as people get discharged from the hospital back to homelessness, as one might imagine. And then also get really unique experiences. What Malia didn't tell you is that if they chase you down and don't go to your appointment, is that then they tell Adam to go hunt you down at your house. So it had a lot of great experiences working with all these folks, and yeah, I think they've covered most of what we do, but we'll look forward to questions.
I'm Ann Bartlett. I'm the Director of Nursing for Milestone Recovery in Portland. I'm in attendance, as well as Bob Fowler. He's our Executive Director at table. Every table is over there. And as I mentioned, I'm the Director of Nursing for Milestone. We have a 3 to 7 day inpatient detox program, so where we fit in the continuum of care for those struggling with substance use. We are at the point where a client is accessing our services for detox. They're ready to make a change. They felt like they're at the point with their substance use where they're, struggling with homelessness. They may have lost their jobs, lost many relationships, and we are kind of the end of the road for many struggling in our community. So we not only have our inpatient detox program, but we have an outreach program as well, the Home Team, which services the Portland community. It's a van that we enlist 2 Milestone employees. They travel around the city. They visit some of the most remote campsites in our communities that most of us are unaware even exist. In the winter times, they may bring them out some hand warmers, just do a general wellness check. One additional great thing that's going on with the home team, just recently in the last few months, we were able to enlist an NP to go out with the home team crew, and basically once a week the NP will go around. They'll maybe go with them to Preble Street, they'll go to some of those remote areas where our clients are at, and check in on them and maybe make appropriate referrals as needed. So the home team really saves our community. It's estimated at $250,000 a year. So basically, instead of EMS or any other of our public services responding to calls, the home team will be dispatched and then make the appropriate placement for that person once they engage with them. So sometimes when a client is engaged on our home team, they may be directed either to our wet shelter or our detox program. Our wet shelter services 41 males every night, and most of those nights we are full throughout the year, especially the winter months when it's particularly challenging for our clients that are struggling to find housing. So that's a 41-bed male wet shelter, so they have to be under the use of a substance or intoxicated in order to stay in that shelter. So we have our detox program, our outreach program, our shelter, and we also have a 6 to 9 month residential program in Old Orchard Beach. And that services mainly clients with main care. We do have scholarship opportunities in that program, but it's a really integrative program. We use motivational interviewing and some really therapeutic techniques to really rehabilitate those that are kind of at the brink of society and looking to make a change. So on the continuum of care, we can kind of assess or touch clients at different points, whether it's our home team, whether clients come to choose detox or potentially utilize our wet shelter or a residential program. One thing I will mention, we are in the midst of opening a new women's sober house in the Portland community. We've seen that women are particularly marginalized when it comes to housing and getting stability post-detox and searching for recovery. So I'm very excited to share with you all more about Milestone, and thank you for having us.
Thank you guys. Thank you all for being here. That's great. So these are our panelists. They're outstanding, and in a minute here they're going to actually redisperse amongst you all, and they will help you discuss this case. And then once we have gone through the case in our groups, they will come back up here, and you all will have an opportunity to kind of present thoughts you have about the case and questions you have about their perspectives on the services. Very helpful. So thanks very much. So you all have on your tables descriptions of this case, but I'm just going to give you sort of a quick summary. So we have here a fictional individual, M.O., and he's a 42-year-old guy. He's been divorced. He's got extreme diabetes, and he originally came to the emergency department, sounds like maybe a week ago, with this really bad leg pain. Comes in, it turns out he's got a broken leg. Undergoes surgery, gets some oxycodone, goes to Milestone actually for rehab. It's determined to be abusing alcohol at the time. Undergoes 6 days of treatment at Milestone for detox. Winds up back in the community and represents the emergency department again because he's really having intractable pain still. And we would like some management for that. So that's sort of a brief summary of the case. You have already a lot more details there. What we'll do now is just sort of have a discussion amongst your tables about the questions that are available to you. So the way that we are going to collect responses is with a system called Poll Everywhere. This is going to require a brief explanation, but you need a phone. To start with, we only want the reporters from each table to do this. And we would like you to answer the first question using this tool.
So question number 2, how do you talk with them about substance use? And the first question that we discussed around that was, is it an appropriate time when he comes back to the emergency room is it an appropriate time to talk to him about his substance use? And we decided that it was. And with a patient like this, you don't know how many opportunities you'll have to interact with him. And second, how we talk with him about substance use, we decided that it would be important to focus on his 6-day detox at Milestone and dig into that and ask him about his experience there and motivating factors to enter the detox program, and ask him about his experience completing it as well, because he did complete the 6-day detox. And then from there, look at other motivations behind completing the detox and future goals moving forward.
Alrighty, great, thank you. Table 1. So to respond to that, actually, I wonder if we could hear from Anne of Milestone.
To add to that, I would say when you engage with this potential patient, when you start to kind of assess how to address, or even if to address the substance use that this client is struggling with, I think it's important to think about how you approach that. Is it more just sitting down with them, face to face, from a very non-judgmental place, and more just getting curious about them? What are some of their dreams? What are, some of their, like we mentioned, the motivating factors? And maybe not necessarily honing in on the substance use, but really making it about them, and empowering them to really disclose to you and offer information. So instead of us kind of digging and prodding, allowing that to come a little bit more naturally, we found at Milestone is a better approach.
Great, thanks. All right, table 2.
We can do 3. So we found this really nice resource guide over here, but the biggest ones we came up with for resources for the client or patient were Preble Street, the Resource Center, and on India Street there's the syringe exchange program, so they mostly deal with IV drug use, but they will also have resources for other substances. So those are the 2 big ones we suggested. Oh yeah, and homeless healthcare partners, yeah.
And just to clarify, which question is this in response to?
I'm sorry?
Just to clarify, question 2?
Yeah, the third one, yeah.
The third question.
So what resources or interventions might you consider in caring for this patient?
Great, thanks.
Okay.
Alrighty. Adam, thoughts?
This is about, this was the like, what would we offer him?
Yeah.
Well, I'll say that my table, I don't know if they were just like sucking up or not, but their answer was that this guy really needs a primary care doctor, someone to follow up with long term, and definitely love that answer.
Alrighty.
And I'll just add at my table, it was social work services there.
Alrighty. People know their audience.
In partnership with homeless health partners and social workers from Preble Street, as well as really understanding about what it is that the person liked about drinking, what was helping them, what was good for them from their point of view, and really just having conversation about the meaning for them, as opposed to judgment. So it's just kind of funny.
Thanks. That's great. You can answer any
whichever question you want.
Whichever one you think you have a most interesting response to.
Okay. So I'm going to go with 4, just to mix things up, which is what feelings arise on behalf of our team. And I think some of our concerns, we were talking a lot about, is he experiencing isolation or not? And he has buddies that he's hanging out with. He has a tent community that he's connecting with. And so I thought that was a really interesting conversation, is that he is disconnected from his family, and he may be divorced, but he may still have strong social networks, which is something really important to consider when you are making, certain types of advice or doing like goal planning with someone, is that their ideas around being housed might be different than your ideas around being housed. I think the other thing that really came up for us too is like what does pain management look like for someone, and also what's driving his desire to have pain management. And I think that there's a lot of assumptions that can sometimes get made around why someone would be seeking oxycodone. And I think it's also really important to consider the fact that like we kept going back to what does he actually want around his using and drinking. We don't know that he wants to be abstinent from anything. Nothing in this says that. And so I think it's really important to consider all those things.
All right, great. Let's hear from Preble Street about community and different definitions of community.
Well, definitely in terms of what matters to this individual. What do they want? What are their needs? What are their concerns? And what are they looking for? As opposed to what are we assuming. Also at our table, we also talked about there are going to be some people who might judge, are they really in pain? What's the purpose? And what that feels like to someone. So really, again, understanding about the dignity and respect of the individual and what that feels like for any of us if someone's deciding if what we're saying we're feeling is in fact true. So in terms of being open to sort of really having conversation and being where that person is, being really important to understand all of that. And recognizing that for this individual, pain is really important and that it's complex. There were a lot of folks at our table who were saying, but what about this very important, very real medical need? What about this? What about that? And it's a lot, so it needs a team. That was the other reason, back to the social work, the doctor, family, any social support system, that it really does need a team approach, and there isn't enough time in the day, there isn't enough time in the 5-minute intervention that somebody might only have on their schedule, so how do we work together to be present for the individual?
Great, thank you. Alrighty, table 4.
Excuse me.
Again, whatever the most interesting question to your table was.
Okay, so we also had a lot of discussion about number 4. Kind of going off of what table 3 said, we discussed some of the same things, but one of the first things that was mentioned from our group was just the anxiety that we'd feel upon discharging this patient, and just to know like what they really might be going back to. Also, we talked about, how much compliance would this patient maybe have, like what is his motivation for change, and what resources might he actually want. So we talked about giving those resources, but also trying not to be too pushy, because the patient has to want to change. So, and then another thing we also really talked about was just how our discussion about all of this really kind of brought the team together, and we thought that that's kind of a way it might impact a team in this actual situation, is just actually getting together and dealing with this and talking about it together really brings the team together, and then you're able to really handle it like a good team. So.
Great, thank you. Malia, do you have thoughts about that?
Sure. So I think that the concern that you raised around sort of anxiety, or where is this patient going to go when you discharge him, I think that's a really important sort of concern to voice, and it's one that I would encourage people to voice out loud with the patient, and to make that part of the conversation, because if the patient's thinking it as well. So by you naming it, it sort of gives everyone permission to have the conversation. And when I'm working with somebody, when I meet them for the first time, it's pretty much the first question that I ask, aside from what's your name and what brings you in today, is where are you going to stay tonight? Where's home for you? And by having that conversation about where somebody is going to stay, you're letting them know that it's okay for them to say that they're not going back to their house. And then having that sort of honesty on the table allows you to talk about the other things that as a medical provider, you might be concerned about. Where is he going to keep his insulin? Is he going to be adherent to his medication program, and all of that sort of stuff. But I think you need to kind of name the biggie here, which is that this guy has nowhere to go. And the best discharge plan the first time around was detox, and that was for 6 days. So he has how many more days ahead that this is going to be the major problem that's going to be on his mind, in addition to the very real pain that he's experiencing.
Thanks. All right, table 5.
So we talked about number 2, again, like many of you other did, the substance use. How do you talk to him about it? What we talked about has largely been said, but just to add, particularly approaching him about a subject that he probably doesn't want to talk about, might not be the right thing to do in this setting right now. We just want to get to know the patient first and foremost. So getting to know the patient is hard to do in an ER setting. I was thinking, I mean, if there's an open family room at Maine Meds outside of the ER, maybe you could take him in there, or just close the door, just try to keep it quiet, do little things that can help make it more of a approachable environment. But first and foremost, we want to get to know him and then maybe bring up the substance abuse if it seems appropriate.
Great. I will at this point open it up to anyone on the panel who has thoughts about that.
I have some thoughts, and then I can.
Yeah.
I'm sure we all have thoughts on this. I think that, aside from, a very emergent situation where, whether you're a social worker or you're an emergency department physician, where you have to act before you're really engaging the patient in any sort of conversation, I think that, in listening to the discussion at our table, I think we were really identifying problems to solve and what's the most important problem. And I think that, what I find really helpful in building relationships with patients over the long term is to think that this person isn't a series of problems to solve, they're a person to know. And so if you lead with that I'm really here to get to know you, and yes, we're going to identify concerns that you have, problems you need to solve, but if you lead with really trying to get to know the person, that's something that is going to make your kind of the problem-solving work that you're going to do, it's going to make it a lot easier, and it's going to make it a lot more enjoyable. And in my experience, it's a lot more successful.
Absolutely, and if we move too quickly into solutions, to fixing, then we're making assumptions about what this person's circumstances are, what they're able to do, which can then reinforce their not being able to let us know what they're really experiencing, and that we're not really necessarily addressing what's going on for them. So the more we can be present for them and engage in what's happening for them, then we can really maybe make a difference, as opposed to how we want to make a difference. And that's hard, and it does take time.
I think the only thing that I was going to add, and it's been alluded to several times, but just to say explicitly is, and I think Malia was basically getting there, is like, it's all about meeting someone where they're at, like the medical answers to this guy, like, I have a broken leg, fix it with surgery. I have diabetes, give them insulin. Like, that's very straightforward and algorithmic, and we can all do that. But trying to figure out where they are on each of those problems and where you can actually make ground on them is huge, and I mean is kind of number one in motivational interviewing and behavioral change.
I just wanted to add as well, for those that are chronically homeless in our community, and even for those that are not, but Milestone, we do serve a number of clients over the years. We do have a rate of recidivism, but that's really an opportunity for us to connect with the clients. And instead of a client, we may serve them 2, 3, or more times a year. Instead of us saying to them, what can we do differently this time? What didn't work last time? we really say, welcome back, we're glad to see you, how are you doing? So really that's where we really find where the work kind of starts and allows for that conversation to naturally unfold. So I think it's good to highlight sometimes, instead of just seeing our clients as, something to fix, what does it look like if we treat them as hospice clients? We're making them comfortable. We're giving them a space to, maybe within the readiness spectrum, they're not ready to change, and that's okay too. And then when they are ready, we'll be able to offer them the resources that may be available to them.
Great. Alrighty, table 6.
So we did question 2 too. There was a lot of overlap, but something that we talked about was what can we do beyond detox that might help him stay sober, and a lot of it went into like what are some underlying issues, like are there mental health issues, or maybe help collect past medical history or family history and figure out what some of the underlying problems are and maybe fixing those, and that could help him stay sober. And another thing that led into was resources for mental health issues. Like we were kind of stuck trying to figure out what kind of resources are available for this population. So if someone could answer that, that'd be great.
Great, good question. Thoughts from the panel?
I'll start. Were great points. Some of the resources that we expose clients to when they come in for detox, we have them for only 7 days. So we try to incorporate a variety of different disciplines, different teaching modalities into their treatment as much as we can if they're open to it. We do have a daily AA meeting that some clients find attractive, others do not. And all of our groups are not mandatory, so if they choose to join in, they're welcome to. If not, they can sit out. So we have our daily AA meeting. We also have Smart Recovery that comes in, which is another daily modality, more focused on behavioral change than the religious component that AA has. We also have the Learning Collaborative. Malia comes over and meets with our clients once a week. If they're looking to connect with services through the Learning Collaborative, they have the opportunity to make that connection in detox, which we've found is really successful for Milestone's end and Learning Collaborative's end. We also offer acupuncture for clients, so the more holistic spectrum, if clients are interested in that, getting them exposed, giving them kind of a tool belt, a list of meetings, or if it's sober housing, residential treatment, IOP, which is intensive outpatient. So, allowing the clients to pick and choose what may or may not work for them.
So work very closely with a lot of different organizations and try and work with individuals around what it is they're looking for, so problem solving and what resources are out there. So we do outreach to other organizations. They do other outreach and provide services on site. We'll work with folks to qualify for benefits so that they can maybe be eligible for some services. We then find other services that might have, let's say, what's called grant slots or something. There are different means for which they can see folks. The Learning Collaborative has had a wonderful opportunity with some psychiatric residents, so that has been a beautiful partnership for some folks. And again, it's been over time, so that getting to know someone, coming over to the resource center, being able to be familiar, to be able to develop relationship, to be able to understand where things are at, and then really be able to work towards goals that are important to them. So we work with a lot of community providers that are out there, and they come to us, we go to them, and to see about connections for mental health, substance use, primary care, so, as well as eligibility requirements for SNAP, food, main care, all of that kind of thing as well. So.
I think it's also, it can be really tempting, like that the list is wonderful, and I love looking at all the organizations and their telephone numbers and addresses. And I think we have to keep in mind that like the act of referring a patient to a service sometimes can make us feel like we're doing our job, but really has virtually no utility to the patient, and that what we need to do is partner with our patients so that they actually access the service that we're trying to share with them. So I think that if we look at like a discharge instructions from any hospital, at the end it will say, it's like the roadmap to like health and wellness, and if we're not supporting patients and along the way to make sure they actually access that service, we're not benefiting them. And I think that part of that process is helping patients get a sense of entitlement, that they're deserving of the support that's available to them, and that they're worth it. It's worth pursuing, that people are going to actually be helpful to them. And it's, when I go to Milestone, I bring my phone with me, and when I'm talking to a client and they say, yeah, I think I do want to meet with a primary care doctor. And so I don't say, okay, great, here's a telephone number. I say, so how about we call right now? And people say yes. So you just put it on speaker and you call and you can get them registered for care. And I know that that's not within, we all represent different roles within the system. But to keep that in mind, like how can I, to the extent possible, make this a warm handoff? It just makes it a more sort of viable referral from the start.
Great. Adam, any thoughts? Or?
Yeah, I would reiterate that it's just medicine and healthcare in general has kind of historically been very passive, and we wait till problems come to us. And that definitely the times that we're successful are when we are walking people across the street to their appointment, or when we are calling Milestone with them and really being proactive about things that we're doing.
Great. All righty. Table 7.
Before Table 7, I wanted Mark to comment a little bit on something that we were just talking about, not while you all were talking.
My name is Mark Swan. I'm the director of Preble Street, and we were just kind of whispering. I think this conversation has been so great, and the panel's doing a great job, absolutely. But I just felt the need to say something about when the question came up about behavioral health services, for instance, and I think we could talk about that in some other systems. It's not as accessible as it might sound, and it was pointed out to me for this audience, we're trying to, among other things, get across the point that it takes lots of different providers and different perspectives and different professions to work with people who have complicated lives, and that's true. So I think that's where some of the answers are coming from, but there's an extraordinary dearth of services, particularly around mental health care for this population. So I just want to make sure we're not overstating that. Joni, you talked about all the providers we work with, which is true, but it is incredibly hard, and it makes me think of the earlier conversation we had about the need for all of us in this room to be advocates, and certainly within social work, that's part of the profession, because the lack of Medicaid expansion in this state has had an absolute, immediate, and direct consequence to people living on the street, to the numbers of people in shelters, to the people standing on corners that we hear about from the business community, for instance. The vast majority of mental health services are exclusively funded by Medicaid insurance, Medicaid funding. And before this current administration, about 70% of the people that walked into our resource center, which is one Preble Street program, about 70% had main care. Now it's about 30%. And so all those people may present with a need, may have a diagnosis, may be really struggling, but because they don't have that magic Medicaid card, the vast majority of mental health services are just not available to them. So So we're piecing it together as best we can as providers. We're looking for grant-funded slots. We're going out of state when we have to. We're doing, private fundraising. All of us are trying to do that. But not to be the bummer tent here, but there's a reality that I think needs to be stated. So thank you.
Thank you. I think that's a very important sort of reminder.
I'm going to tell them. Yeah, so this is my opportunity to say, go to Augusta. Even though we had a referendum that we won by 58% of the vote, voting for main care expansion, the governor and DHHS is not going to give a plan to the federal government, which is due on Tuesday. And so if any of you are interested, there is a press conference at noon on Tuesday that the Speaker of the House is going to be there. We're going to have Democratic legislators, Republican legislators, providers telling stories, patients saying that this is outrageous and the public needs to know what's happening in our state. So I will gladly send everyone who is on the mailing list here how to get there.
Thank you, Julie.
So table
7 is where we're at.
Thank you. So in addition to all the other things that have been brought up, we thought it was very important that, we can look at the social history and how this patient's coming in, and we could easily jump to assumptions. And we decided it was very, it's important not to do that. There are very real reasons he could be in legitimate pain. He could have alcohol in his breath because he's in DKA. So it was really important to not delegitimize the patient and to get on his level. And so we all kind of pointed out too that we all were kind of uncomfortable in this situation. And so we actually spent quite a bit of time kind of practicing some motivational interviewing on how we could do better in this and kind of role playing the scenarios that would go through that. So those are some additional things that came from this table.
Those are great thoughts. It was definitely the intention to draw some discomfort. What are your thoughts, panel? I guess that's been said.
So can you repeat sort of what was the sort of the discomfort that you were getting at?
I think it was, I don't know, I think it was, for a lot of us, it was just like anxiety associated with it, and how do we bring this up without judgment, without confrontation, or not necessarily confrontation, but how do we keep from escalating the situation? How do we actually get the patient involved without driving the patient away?
And if I may, is this at all sort of also about recognizing your own reactions to pieces of the patient's story and how that might be shaping the way you approach the patient?
Right.
Concerns that could lead you to the wrong path.
Mm-hmm. I can only speak from my experience. I mean, I'm at this point way more comfortable having those conversations than any other type of like networking or professional conversation. So this is like, I'm way more comfortable there than I am right here. But I think that it's practice. And I think that, and again, I'll just speak from my own experience. Like I'm a generally sort of quiet person, and that changed when I started working at Preble Street, and it was my job to sit down next to somebody that I didn't know who was potentially actively psychotic, under the influence of drugs and alcohol, hadn't eaten for days, and say, "Hi, I'm Malia, how are you doing today?" And, what brings you into the courtyard, or what brings you into town, and just having conversations and having a little faith that it's going to be okay, even though you're not going to be you can't anticipate where the conversation is going to go. And so those conversations have turned into that's my work now, that's my career, and I love it. But I think that, I can say as a patient and as a learner myself now, that a lot of emphasis is placed on kind of leading questions and structured conversations where we're trying to arrive at a certain place, and once we get to that place, it's going to lead us to these possible solutions, and we're going to be able to sort of check off that we've addressed the problem. This is not the type of approach or conversation that's going to work, in my experience, with this patient population. Because if it was an easy sort of fix, we would be able to fix it on conversation number one. So I would just say, if you're uncomfortable having the conversation, just start having the conversations, and try to have a sort of sense of humor about it. And you'll probably, I think what I love about the work that we do at the Learning Collaborative is we work with learners. We work with people who are in their first year of medical school, their first year learning to become a pharmacist or a dentist, and they get to follow us around and see us do our unconventional work. And people really like it, unless they're lying to us, but I think they actually really do like it. So I would just try to build that into your practice however you can. And if you want to sort of come down and work with us for a couple of days, you'll get a healthy dose of how to initiate these sort of difficult conversations.
I just want to add that when you say people really like it, all people really like it. It's amazing when someone takes the time to look at them and just say, hey, without an agenda, without driving it, without the structured questions, what can happen, what can come up, and then what can change for someone who has been so afraid to go talk to anyone with certain credentials after their name or part of some structured healthcare system. But it's amazing when you can open up and just be there and have a conversation, what can happen and what someone can share, and then what they can be open to, something that they've been so frightened for, so afraid of judgment, so afraid of what would happen if they look at this, what it may mean for them. And it's absolutely incredible what can be, but it's about practicing and being genuine and taking a risk, and it's okay, and giving yourself permission to really just have it be okay.
I was going to tell a quick story that I won't tell the whole thing because I wouldn't ever be able to do it justice, but one of my favorite doctor mentors along the way he always tells a story about this patient that he saw time and time again, and he just like couldn't stand these interactions, like didn't like going to them, and they drove him insane, and he just like frankly didn't like this patient. And after a lot of years, one day, I don't know exactly what it was, but it clicked that this patient reminded him of his mother-in-law. And I tell this story not to pick on mother-in-laws, but that it was a turning point for him where he was able to recognize his bias towards this patient. And so I think the fact that you are like recognizing that you're anxious about it is really impressive, and that if you're the most like liberal, open-minded, like harm reduction model person in the world, like there are things out there that are gonna like get you riled up and make you biased, and that's fine. It's just being cognizant of them and being aware and how they affect what you think, say, and do is really most important.
Just wanted to add to that, and it's great that you're recognizing that for you that might feel uncomfortable to start engaging in those conversations, but just reminding ourselves that it's okay to feel uncomfortable. It may not feel natural at first. It will get easier with time, but if you're uncomfortable, you can only imagine the feelings that the patient is going through, and for us to kind of take a back seat and let them drive the conversation, again, find out what their interests are. And if you start to feel yourself going into a power struggle, one thing that I've found really effective, if I'm assessing a client and they're, getting agitated, perhaps taking a step back and saying, I'm sorry, and being sincere, that goes a long way in our practice. And one thing I wanted to mention too, that kind of coincides with the non-judgmental and destigmatizing approach is letting our clients know that there are harm reduction opportunities for them. We have a clean needle exchange in Portland that we're really fortunate to have, and the needle exchange is great about educating clients and the clients that they interact with on clean needle techniques and supplying necessary supplies for them so that if they continue to use, they can do it in a safe manner. And us at Milestone, we dispense Narcan kits. We teach any client that's interested, if they are coming in withdrawing from opiates, we will explain to them the importance of Narcan. All of our clients have the best of intentions when they leave us, but we do know that studies show those that leave detox are at highest risk for relapse once they leave detox. So we want them to be prepared when they leave our doors. We don't want to turn a blind eye and think that they'll never use or never drink. So giving them the necessary tools, making sure that they know, giving them the Narcan, knowing how to use it, so perhaps they can have that for themselves or a friend is an important component.
That's great, thank you. So for those of you who, quick side note, those of you who may not be aware or might be interested, there's a significant body of work on something called implicit bias, and that's very germane to this particular conversation and worth looking into if you're interested. But let's go to table 8.
All right. I've had a lot of questions. I've been festering over here. So my first question is, I've been hearing a few people say, maybe it's not the right time to address the substance use, to have that conversation. But, and I'd love to hear your thoughts on it, but personally, I don't find it to ever be the wrong time to address that issue in the proper manner, of course. Like we talked about for question 2, the motivational interviewing, like you guys were talking about, and how it's important, even if it's a few-minute conversation, even if you're planting the seed with someone, how important that is to just plant that seed and to continuously, even if your second and third conversation's the same, just planting that seed and making the person aware that that we care about them, that they matter, and because they might not have that from anywhere else. So having that conversation, how important that conversation is. So I was curious on your take on that. And then the other thing we talked about was question 3, the resources or interventions that we considered. Malia, we talked about you being a great resource. The other thing that I personally talked about was I work with Greater Portland Health, and it's on Preble Street. I don't know if anyone's familiar, but we actually see a lot of patients just like this gentleman that come in, and the really cool thing about our program is that everything's under one roof. It's kind of like this dream, like medical, because everyone's kind of together and working together. I'm the dental end of it, and in order for them to see me, they have to see medical first. They have to get financial counseling where they would be either put on a sliding scale fee or given free care. They would get mental health screening, and so all the different providers are there in one building and can do the handoff, which is a really, really great thing, and then they can schedule them with dental and get their needs. And the thing about being there that I've learned is that even though we might only see this patient once, it's making the most out of that time with your patient. So, addressing that chief complaint, but also hopefully planting that seed too, giving a little bit of education and just hoping that we can establish a relationship and how important that is with the patient. But that's kind of what we talked about for resources and interventions. And the other thing that I was thinking about when you were talking about that just came into my mind about hospital discharge was a few months ago I
I was helping a lady out. She was a single mom on main care. I had brought her into the emergency room. She actually went in for a toothache, and she was currently undergoing chemo for cancer treatment, and the discharge paperwork was actually not accurate for her to get care, because she wasn't established. Believe it or not, she still didn't have a primary care that she saw all the time, even though she was going through treatment, which I thought was really fascinating. That's not my area, so I don't really know. But she didn't have a dentist. She hadn't had dental care in years, but the chemo was affecting her teeth. And but what I thought was really interesting, I looked at her. She let me look at her discharge paperwork, and I immediately was trying to see what they were recommending, and I was just like appalled completely. So of course I called the emergency room the next day, and I was like, listen, what's going on here? This is, where are you getting your information from? And what they told me, they were really nice, and I found out that each doctor, or this is what they told me at least, each doctor just kind of collects bits and pieces of what they know, and they have on different computers, they have different providers, and they just print off whatever information that doctor might have saved in a file for that patient, for that provider. So I thought, when you were talking about that and how important it is to give people resources, what can we do? I mean, is there somebody else that's going around? Now, mind you, I made my own list and emailed it to them, but what can we do as, future providers or as providers to help make these connections? Because what I'm hearing is the most important thing is connecting. It takes this village, and how do we connect everyone? How are we, I don't know.
Sorry, so those are great questions. In the interest of time, I have to apologize.
Yeah.
I think we're gonna have to pick one of them and kind of go with it. Is there one in particular that you are most interested in?
Finding out, I don't know, you pick, I don't care. It's
Well,
fine.
all right. Sorry. Well, maybe we'll roll with the first one? Sure. All righty. So to restate, if I understand correctly, the first one was kind of about when is it not the right time to talk about substance abuse and
Isn't it always the time?
right, isn't it always the time?
I think the answer is that it is always the time, you're right, to check in on it, and that that is part of the thing that we're talking about is screening people, and but I think the finer piece that we're trying to get to is that when you hit that brick wall, not to try to beat someone over the head with it, it's yes, you absolutely should be talking to someone about their alcohol use, sure, but if they are pre-contemplative in terms of their stages of change, and they have zero idea of, or zero thought or plan of changing their behavior at all, then telling them to go to AA and walking them to Milestone is useless. So I think it's just a matter of, yes, screen every time, but then kind of realign your priorities with something that you might actually make some ground on.
So if I can sneak in about the other question a little bit. I just think one of the things that's really important, in terms of the resource list and the resources that are out there, is that what you're recommending is important to the patient as opposed to what we want for them. So to give somebody something that may not be of any use, is this person, back to the story, camping out, how are they going to take the script to get to a doctor? What transportation, what resources? Someone talked about storing medication. What's important to them? A lot of the resources that are out there, like I saw a list earlier, they're insurance-based and cash-based. So what is that individual's story? So that if you want them to come back and feel like they matter, then it's going to be really important that what we give them is what they're looking for, as opposed to what somebody else wants for them.
I think that in this scenario, and I'm biased because I can see actual patients that went into this scenario, but I'm least concerned about this individual's substance use at the moment. And I might bring it up, but it's not, I actually might bring it up and intentionally table it. And I'll do that with patients often. If they're coming in and they're, like in this case, this individual is in pain, if I'm doing, an initial sort of assessment, and I use that term very loosely, but I'm having an initial conversation with somebody, I will say, so I have some things in mind that I'd like to help you with. I'd like to hear what you would like help with, and then maybe we can chat about where there's overlap, and maybe we can kind of put some things in a compartment for a while and come back to them later. Because, going back to this scenario, I'm not going to be able to, and I don't think anybody is going to be able to sort of manage that chronic disease today. But we may be able to manage his pain today, and we might be able to help him find a way to pay for that prescription today, and we might be able to give him a bus ticket today. And so I think that the gentleman that was at our table, but I think had to leave, said about this scenario, this is a big project. This could take 5 years. And it could take 5 years, it could take way longer than that. So I think that we need to take the long view. Yes, we need to seize the moment and seize the opportunity, but we may need to start really small and build from there.
Great, thanks. All right, table 8. Questions, and unfortunately this will have to be a relatively brief question. All right.
It was that. But we all agreed on using a very non-confrontational approach in regards to, let's scratch that. What we felt was really important was to develop a therapeutic relationship. That relationship building is the underpinnings of all areas of us to be able to intervene. So we have to have the ability to listen, to be comfortable, even though we are uncomfortable, with what the client patient may be saying to us about their particular situation. Showing that you are caring, how do we show that? Being respectful, listening, not trying to do a quick fix, and basically trying to talk them into getting something that they don't buy into. And I think being present, just being present and being aware that our nonverbal communication can sometimes supersede any attempts we make at verbalizing correctly, or how should we interview our clients. So I think the underpinnings of the therapeutic relationship was really important.
Excellent, thank you. It sounds like that's actually very consistent with what you were saying just now, Molly, is that correct?
Yeah, I also think that, and this is sort of my personal / professional opinion, is that I'd like us to sort of stretch the definition of what therapeutic means. I think that when we say therapeutic, we think sort of clinical, and we think therapy, and we think of sort of a gentle approach, and that's not. I feel like that very rarely works in my experience. I mean, yes, I take a gentle approach, but an honest and direct approach works very well. A sense of humor goes a very long way, and so. A therapeutic interaction for me is getting somebody a cup of coffee. I mean, that's a therapeutic interaction. Or, having a patient, like developing a rapport where, we are laughing or sort of poking fun at each other, like that is a therapeutic, that's a therapeutic relationship and interaction. So yes, we want to create those spaces, but they do not have to be formal, and they don't have to look like sort of a billable hour in a in an office. They can be much more casual.
Great. Thank you. I see you right there, Julie. Do you want to do this right now? Is that your thought?
Well,
we have no more
wrapping
questions,
up?
I think, for the moment, yeah.
Well, for those of you who don't know me, I'm Julie Shermer. I'm a clinical social worker. I'm faculty at the Family Medicine Residency Program, as well as Family Medicine Assistant Clerkship Director for the Family Medicine third-year rotation for medical students. And I'm a UNE social work supervisor with 2 of my students in this room, so I'm very excited. So I just want to thank all of you for the work that you do in our community and for making this much better, safer place for our community and for us. What I want you to do is hopefully hang out a little bit longer after the proceedings, because I have something for you. But I also wanted to really commend all the people who have contributed to tonight's event, and I will be asking them to come up as well and stand up. But how I'm going to do that is by presenting a honorarium or a monies to Preble Street Resource Center. So Mark Swan, if you want to come up. And you can get a lot on the internet. I got a lot of scoop on you, Mark. He's a Bowdoin graduate. He has been, besides doing all of his hard work at Preble Street Resource Center, he has been, he's received Bowdoin's Common Good Award. He has been nominated for the Congressional Medal of Honor as one of 20 national finalists for an award honoring those ordinary Americans who become extraordinary through their indomitable courage and selflessness. And when I think of Mark, he and I have been in the community for a long period of time. So even though I haven't really known him, I know of you. I know of your advocacy. He's a tireless advocate, as you know. He is selfless. He's selfless, not selfish. He's courageous, is able to put things out that most people feel kind of uncomfortable with, but it's the truth about the homeless population. And he's been a tireless collaborator and convener when our community around homeless care has fallen apart. He has picked up the strings and brought people together to make Preble Street so strong. So, Hamish Haddow and Lee Johnson and I last year through Primary Care Progress applied for grant monies through Tufts Community Service Learning Project. So Jen Greer-Morrissey, could you stand up just because she is the person who has allowed us to give this money to Preble Street Resource Center. Thank you. Yes, so a third of the grant for Primary Care Progress is going to Preble Street because of how they're helping our students. So our students have a long history, even before Primary Care Progress, doing something called Bounty Share that we would love all of you to get involved and participate in. It's helping in the soup kitchen on weekends. And teams of students will go in and do that. Our students are doing some education with the Preble Street case managers. They're also doing education with family crisis shelter residents. And we are also developing a home visit project for vulnerable patients at Family Medicine and our internal medicine clinics at Maine Med. So that's my plug. And here is Primary Care Progress's gift to Preble Street. Thank you. So we now have a treat for all of you. You don't have to fill out any evaluation forms, but we are going to use Poll Everywhere.
We are indeed. Before we go quite to that, let's applaud our excellent panel members, and you guys also are free to return to a more comfortable seat. You guys are free to go back to your seats if you would like, unless you want to hang out up there, which you're welcome to do that too. We have some chapter meetings going on. Our next one is the 26th, and that will be at the Family Medicine Center on Congress Street. Some of you may be familiar with it. If not, you can Google it, and it is what it says it is. We talk about things like Bounty Share, which is the project we just discussed a little bit. We talk about the Home Visit Project, which is underway now and is a way for medical students and students from other disciplines in healthcare to try to get involved in doing some home visits for people who might benefit from that. We also have other leadership opportunities within the organization, including membership and involvement in a national leadership conference that happens annually, as well as about 1 million other ideas for educational community projects that have been stewing and gradually gathering momentum over the last 2 years. So many exciting things if you're interested. The evaluation. All right, so the Poll Everywhere thing we did earlier has a phase 2, and it's this. All of you, if possible, will be asked to participate in this particular activity, and this is going to be our way of evaluating whether or not this was a useful expenditure of your time this evening. So, we have these questions, and once everybody has their phones out and is ready, it's going to work the same way as it did before. Those are the options. So I'm going to go back to the other screen for a second so that people don't feel pressure, but the options are basically very closely met, neutral, not closely met, and not met at all being A, B, C, D, or E. So E is bad, A is great. How closely met were the objectives? Identifying complexities of homelessness. I'll just stay on this slide. I trust you all to be objective. So it looks like 59%-ish. The winner is clearly closely met. I'm sorry to the person who felt it was neutral. We will accept your feedback and attempt to do better. Option number 2, increased comfort in discussing and assessing substance abuse. And I'll give this one 30 seconds total because that felt interminable. Alrighty. Looks like closely met is again the winner with 74%, a landslide. Very closely met, a close second. Not that close. Very good. All right. Number 3, examining the difficulties encountered by teams in caring for persons who are homeless. Same rules. All righty. Did better. Whoop. Spoke too soon. Did slightly better on that one, which is good. So it seems like our areas to improve are resource description and difficulties from the care teams. Excellent. This is very helpful. Thank you for participating. What do you think was successful? So this is going to be, I believe, more of a word cloud style thing like before. So I would try to stick to like maybe 3 words maximum. Scrolling off the bottom of the screen if you're wondering. No bias. It's bold. And I'm seeing a lot of sort of discussion, teamwork, interdisciplinary, panel. Seems to be the theme. There we go, a couple of hot words there. Alrighty. I'm sensing that everyone has already responded to this and we're now just getting delayed responses, so we're gonna move on. What would you change to improve tonight's event? And this is a similarly kind of 1 to 3 word style response. Agreed. Interesting. So this is actually very interesting. A bunch of the things that have been raised are things that we indeed ourselves identified as potential weak spots. So this is good. This is confirming our suspicions. I think we did record it for viewing at a later time. So that's good news. Alrighty. I think we're done. Rock and roll.